Well, I'd like to start by saying buenos tardes. And after that, I won't really be able to say anything else in Spanish. But I do want to thank Dr. Madero, Dr. Herrera for inviting me, Dr. Gomez for the invitation, and to all of the audience for coming today. It's a pleasure to, this is my first time at the IMIN meeting. And it's really an exciting meeting. The agenda looks great, and the posters were really very stimulating. So I appreciate the invitation. So my goal today is to give you an update on chronic kidney disease. Let's see. And in particular, as you know, the definition of chronic kidney disease has created some controversy. And there has been some substantial resolution of the controversy, and I'll spend most of my time talking about that. But I do want to give you a much broader context for my remarks. So I'm really here to deliver what I think is a public health message. And the public health message, I believe, is best stated by this statement from World Kidney Day in 2008, that kidney disease is common, harmful, and treatable. And I think the way to approach issues of chronic kidney disease between what we do as nephrologists and the public health is in the production and implementation of guidelines. And for that, the institution that I've had the privilege to work with is KDIGO, and their mission statement is written here: to improve the care and outcomes of patients with chronic kidney disease worldwide through promoting coordination, collaboration, and integration of initiatives to develop and implement practice guidelines. So my goals for the presentation will be to tell you a personal story, to review the definition and classification of CKD, the controversy, the KDIGO conference, work that has been done since then to address further questions, and then the consensus, the revised CKD classification, and I'll conclude with my perspective. I got started a little bit late. I'll try and get done by about 5 to 10 minutes before the hour to leave time for questions, but I apologize if I end up running a little late. So this is a photograph of my wife's parents. Her mother was from Austria. Her father was from Canada. And he had polycystic kidney disease. And he died at the age of 56 without being able to receive a kidney transplant, without being able to receive hemodialysis. In the years before, in the United States, the federal government paid for dialysis treatments. He never got to see his children marry. He never got to meet any of his grandchildren. And he had a very hard time at the end of his life. This is my wife and our son. She also has polycystic kidney disease, but she's been fortunate to grow up a generation later, during which times we had dialysis and transplantation to look forward to, but no good treatments for polycystic kidney disease. And we, of course, watched as her kidney function went down and as her kidneys enlarged, as the course of her disease progressed. And I was really quite frustrated because I would have liked to be the kidney donor, but we were ABO incompatible. So I couldn't be a donor, and we went through a lot of anxiety searching for who could be the donor. But even with all that I had known and learned as a nephrologist, I did not really foresee the development of kidney exchange, where I might be able to donate to this gentleman whose wife next to him couldn't donate to him but she could donate to this gentleman, whose wife next to him could not donate to him, but she was able to donate to my wife 3 years ago next week. So I've had the pleasure of being a kidney donor as well as a kidney doctor. Kidney disease is a public health problem in the United States and around the world, in Mexico and everywhere. In fact, a particular burden in Jalisco. And everyone has to do what they can, but for each person affected, kidney disease is a personal problem. And there are no unaffected family members. All family members are affected. So when I talk about the work we do with guidelines and the importance of CKD, I'm really talking about the future. I'm talking about our family's future, the future of all families with kidney disease. I'm talking about the future of nephrology. I'm talking about the younger members of the audience who are the future of nephrology, that we need to address seriously the problem of chronic kidney disease at a public health level. So 10 years ago, we produced these practice guidelines. I had the good fortune to be chair of the work group. My colleague, Joseph Koresh, was the vice chair. We've had quite a 10-year collaboration since then. And Joseph Lau at that time was evidence review team director. Okay? And we produced these guidelines for CKD evaluation, classification, and stratification. And what we really did in these guidelines was to introduce a conceptual model of chronic kidney disease where there had been no explicit model before. We simply introduced that kidney failure, which is what we knew the most about, was the end stage of a disease which must have started before that. And before kidney failure, there must have been a phase when the kidney function was reduced, marked as a decreased GFR. And before that, there was a phase when there was damage before the GFR was reduced. And we reasoned that if we could detect the damage and the decreased GFR before kidney failure, we could implement treatments to slow the progression of kidney disease. And that prior to damage, there must be a phase when there was risk, an increased risk, which could be detected in the same way that cardiovascular disease risk factors lead to the anticipation of cardiovascular disease. Now, this horizontal axis depicts the kidney outcomes. And in this direction, we see the progression of kidney disease. But in principle, there are some instances where there's remission of kidney disease. A person with a kidney failure can get a transplant and can get back to this stage, or perhaps back to this stage. A patient with lupus nephritis can be here and move back to this stage. So we have the hope of remission, but we don't have very many treatments at this point to make kidney disease remit. We also see that there are diagonal arrows at all stages of disease which lead to complications. And there are a whole host of complications of chronic kidney disease. Cardiovascular disease, really recognized decades ago, but came to the forefront in the late 90s. Drug toxicity, and of course this is what we nephrologists spend all of our time doing, is going around and making sure our patients are not on toxic drugs and that the doses are reduced. The metabolic and hormonal complications that we call uremia when they're very advanced. And there's a whole host of other complications, infections, cognitive impairment, frailty, that we're not used to thinking about as CKD complications, but I'll return to this at the end and I'll try to make the point that I believe these are CKD complications. Now, of course, once you make a conceptual model, you have to define the disease. So we define kidney damage as something that could be detected by a biopsy or by markers, or a patient with a kidney transplant, we said by definition has kidney damage. But we don't biopsy people very often, and not very many of our patients have a transplant. So most of the time we ascertain markers of damage by the urinary albumin concentration, particularly in public health programs. And this is the albumin to creatinine ratio in milligrams per gram that is the threshold for the definition of kidney damage. We defined a threshold of GFR less than 60. We rarely measure GFR, we usually estimate it, and I'll be talking later this afternoon about estimating equations. Kidney failure we arbitrarily defined as a GFR less than 15 or treatment with dialysis. And based on these definitions, we could do for chronicity, we said it was more than 3 months. With these definitions, we could do surveys in epidemiologic surveys of populations, and the one that I'll be referring to are the surveys of the N. Haynes population, which is a representative population survey in the United States. And we demonstrated through that 4.8% or 9.7 million people in the United States have kidney damage, that 6.7% have a decreased estimated GFR, compared to 0.2% with kidney failure. So kidney failure is just the tip of the iceberg, right? Chronic kidney disease is a much bigger problem than that. Excuse me, I've gotten ahead. And altogether, it's 11.7% of the population affected by chronic kidney disease. So this is a different way of thinking. That's more than nephrologists can take care of. This is a general medicine problem, and we need to deal with general medicine physicians. So this immediately led to a large number of concerns. Those concerns are that the prevalence of kidney disease it's too high. This is too common compared to the incidence of treated kidney failure, especially in the elderly. There was a concern that the terms disease was not appropriate. It should be called pre-disease or a risk factor, that the estimated GFR might not be right compared to the measured GFR, that the spot urine albumin to creatinine ratios might not be right compared to timed albumin excretion rates. And these surveys were really based on single measurements rather than repeated measurements over 3 months. There was a concern about the coherence of the definition because there appeared to be some patients at earlier stages who were at higher risk of adverse outcomes than those at later stages. And overall, there was a concern that maybe these threshold values for GFR and albuminuria should vary according to age or sex or race, or whether the patient had diabetes or hypertension. So as a result of that, KDIGO held a controversies conference in 2009, and KDIGO, along with KDOQI, established a position statement that the definition and classification, the debate should be about patient prognosis. So the purpose of the conference was to evaluate the relationship of estimated GFR and albuminuria with prognosis, and to use this information to evaluate the definition and classification of CKD. Here were the members of the planning committee, and this has been published in Kidney International in 2011. And I will show you some of the results from this. Although it's been published already, it's well worth reviewing some of these results. So we wanted to define the CKD outcomes and risk factors, and we said that a priori we were interested in the kidney disease outcomes. Kidney failure as ESRD, progression, meaning a declining GFR or AKI, and that we were interested in mortality and cardiovascular disease. There were a number of things that we were interested in as potential complications, but that we did not have uniform data. And we wanted this conference only to be about data. And we said the risk factors that we would evaluate would be estimated GFR and albuminuria, that we would adjust for age, sex, race, cardiovascular disease, clinical events, and risk factors, and we didn't have uniform data to adjust for subclinical measures of CVD, other comorbid conditions, education, socioeconomic status, and treatments. So I'll show you a large number of slides that show the relationship between these two factors and these outcomes. And we wanted data. So we invited all of the cohorts that we knew had data with large numbers of outcome. So we had 53 cohorts that initially accepted our invitation. 8 of them had to be excluded, so we were left with 5 cohorts at the time of the original publication. So the initial data I'll show you will be about on 1.5 million people. I'll show you more recent data collected on up to 2 million people. And these cohorts were divided into 4 types. General population cohorts, abbreviated GP, in which we had albumin-creatinine ratio. And these were actually selected through a systematic search of the medical literature. Then we had general population cohorts with dipstick data. This is 1.2 million people. High-risk cohorts, meaning they came from populations with cardiovascular disease, hypertension, or diabetes. And then the CKD cohorts, some that you're quite familiar with, the ASK cohort, British Columbia cohort, the MDRD group, the RENAL study, the RAIN study, most of the large renal cohorts that have presented data. And these investigators gave us their results in a format that we were able to do a meta-analysis in order to provide the results today. So the results today, I'll show you, are set up like, I'll show you a lot of slides set up like this with estimated GFR on the horizontal axis and the adjusted hazard rate for the clinical outcome on the vertical axis. And we'll be looking at clinical outcomes of all-cause mortality, cardiovascular mortality, ESRD, AKI, and progressive CKD. Now, these results are the results from the general population cohorts using ACR as a continuous measure or using dipstick. I want you to appreciate that each point on these graphs, not only these points, but all the points in between, represent a meta-analysis of all of the cohorts, okay, that participated. So we have, if I had a fancy graphic, I could point on a point and the forest plot would show up behind it. Right? In the black line, we have subjects who have urine albumin to creatinine ratio less than 30, 30 to 300, and greater than 300. So this is the typical microalbuminuria range, macroalbuminuria range, and no microalbuminuria range. All the points here are relative risk adjusted to a common reference point. The reference point was 95 for GFR. And you can see that the curve is relatively flat between 75 and 105 and starts to pick up, indicating increased relative risk. And it's statistically significant everywhere the curve is a circle, or everywhere the dot is a circle, and goes to about a hazard risk of 4 for all-cause mortality once you get down to a GFR of 15. And this is significant, okay? Just below the threshold of 60 used to define CKD. And that for patients with microalbuminuria, the curve is flat between 75 and 105, but it's higher than the reference point, indicating about a 2-fold risk, even if the GFR is normal. And in these people, as the GFR declines, the risk goes up. And for macroalbuminuria, it's about 4-fold higher, even when the GFR is the same. The curve is relatively flat, and then it goes up in this direction. So this is really quite a uniform way of presenting this. The GFR, the albuminuria appear to be independent risk factors for all-cause mortality. The thresholds used for the definition of CKD of 60 and ACR of 30 appear to be below these thresholds. There does appear to be risk. The same is true for cardiovascular disease, except the threshold is a little higher. That is, there's higher risk for GFR less than 60. Same for albuminuria, right? Same for macroalbuminuria. For ESRD, the threshold is substantially above 60. Here it's closer to 75. And you see, of course, that the relative risks go all the way up to several thousand. The absolute risks are lower, of course, but the relative risks are much higher. And we see the same for acute kidney injury, and we see the same for progressive CKD. So we really see, with a tremendous amount of data, a relatively uniform pattern of risk. Many of the cohorts had reported somewhat different results, but that really is because they had different people. When we do the meta-analysis that finds the best common estimate for these risks, this is what we saw. Now, you might like to see a categorical analysis rather than a continuous analysis, and that's what we've shown here. These are the GFR categories. Here's the line for 60. For GFR, albuminuria categories are across the horizontal axis, and here's the line for ACR of 30. Right? And these are the same 5 panels, and within each panel is the hazard ratio for that outcome compared to the reference category. So for the general population, the reference category is, for all-cause mortality and cardiovascular mortality, we have enough events so that we can have a very narrow reference category, and it's GFR 90 to 105 and ACR less than 10. And you can see that by the time you get to a GFR less than 45 to 60, there's a relative risk of 1.3, and bold means significant. And if you're at the higher GFR, by the time you get to an ACR of 30, your relative risk is 1.5, and the relative risk is 1.4 even at an ACR of 10. So there's risk below the microalbuminuria range. So these are really the same kind of results, because after all, it's the same data. It's just shown to you differently. But we have then colored the cells according to the magnitude of the relative risk. And arbitrarily, we colored 8 cells green, the lowest 8 cells green, the next cells yellow, the next highest cells orange, and the highest risk cells red. And you can see a similar pattern between all-cause mortality and cardiovascular mortality in that we've bolded these numbers, that the risks are significant here, and the pattern. And we really see the same thing with the kidney outcomes. Now, for the kidney outcomes, the whole green is the reference cell, because there aren't enough kidney outcomes to have a reference cell this small. But you see that once you get below GFR 60, there's high risk. And once you get to ACR 30, there's very high risk. And this leads to a region of risk like this. So based on that, we thought that we not only have good definition, but we could actually stratify risk and create stages of kidney disease, not only according to the GFR, but according to the ACR. So this was the composite diagram when we simply averaged those 5 diagrams, and this is the staging system that will be present in the KDIGO guidelines. We just finished a work group. The new KDIGO guidelines will be out in January of 2013, and they recommend these for the GFR stages of kidney disease, and these for the ACR stages of kidney disease. And they recommend explicitly no change to the definition of CKD, but a change to the classification of CKD, where it's classified by GFR, as before, by albuminuria, A, and also by cause, because some causes of kidney disease are different than others. Diabetes is different than polycystic kidney disease. And if we use the same NHANES survey to fill in the proportion of the population in each of the cells, we get to something that looks like this, where the prevalence of CKD is 11.5%, just what it was before, because we didn't change the definition of CKD. But we can say now that among those with CKD, 73% are in this moderate category, the yellow. The higher risk group is this orange category. It's 18% of the total with CKD. And the very high risk group, really, all this red, is about 9% of the CKD group. Okay, so 9% of 11%, it's about 1% of the population compared to 0.2% on dialysis. Now this, what had been very contentious, in fact, was CKD stage 3, which was a large percent of the population, 6.25%, and it's quite clear why there was so much contention. Right? CKD stage 3 included this group from 30 to 59, and it includes some people in the yellow, and it includes some people in the red. So of course there was a lot of debate over how bad is CKD, and now it's really quite obvious. Well, it really depends not only on how low is the GFR, but how high is the urinary albumin. And according to the new classification, this single box here, GFR 45 to 59 without albuminuria, where there's still some debate as to what's, how important is this. This is 3.6% of the population. And this is still a large population, and we could still have a debate about this population. But it's a little less than half the size of the population that we were debating before. So there are some important remaining questions. And I think the most important questions were, are these eGFR and albuminuria risk thresholds for the CKD definition consistent across subgroups defined by whether you have hypertension or not, whether you have diabetes or not, how old you are, whether you're male or female, and what's your ethnicity? Is it a consistent threshold to be applied across all of these groups? So the CKD Prognosis Consortium, which is the cooperative group that Dr. Koresh and I lead, now have published on all of these subgroups with now more than 2 million participants from 46 cohorts. So I'm going to give you some discussion, some talk about hypertension and age today. But we have published these results in the past year in Lancet, in JAMA, a paper about to be published in the British Medical Journal, and an ASN poster. So we now have used this large data source and these methods to try and answer the next series of questions. So I'm going to show you a number of graphs that look like this, and I think I'm going to have to squint in order to make sure that I describe them right. So this is the investigation of hypertensive versus not hypertensive people. This is the GFR graph laid out just the same way you've seen it before. Okay, the diamond is at 95. This is the reference point. This is all-cause mortality. This is cardiovascular mortality. And in the blue are the non-hypertensive, and in the red are the hypertensives. And these are both groups compared to this common data point for each of them. So a GFR of, I think, 95. And what you'll see is, of course, the hypertensive group has the higher risk for all-cause mortality. No surprise, right? The non-hypertensive group is at a lower risk. Okay? And the risk threshold is at about 60 for both of them. But the important thing that we want to show here is the hypertensive group is at higher risk. But if you compare the hypertensives to the hypertensives and the non-hypertensives to the non-hypertensives, then we're putting both curves down at this common reference point. And then we see that the risk for the non-hypertensives compared to a non-hypertensive person at a higher GFR is steeper. Okay? And every place you see a blue star here means at this particular GFR, and there's a dot at every point, okay, is significantly steeper than the red curve. So the GFR threshold of 60, of being below a GFR threshold of 60, is more important for a non-hypertensive person than a hypertensive person. Their absolute risk is worse if you're hypertensive, but you're not safe if you're non-hypertensive. The same thing is true for cardiovascular mortality. Here, the risk gradient is steeper, but if you compare each to their own, you see that the risk rises faster in the hypertensive group, and this is a significant difference. These are interaction tests. Now, the same thing is true for urine albumin. Okay, the higher the urine albumin, and here's a threshold of 5, okay, the higher the risk for all-cause mortality. Right? And this is true for hypertensives and non-hypertensives, and the risk is a little greater in the hypertensive group. But if we take away this difference and adjust them to the same reference point, in fact, the risk is identical and even rises a little steeper in the hypertensive group once you get out here. And the same thing is true for cardiovascular mortality. The hypertensives have the higher risk, right? But when you account for that higher risk, the non-hypertensives have a steeper risk gradient. So it's easy to accept albuminuria as a risk factor for hypertensive patients. It's just as important a risk factor for non-hypertensive patients. Here is the risk for ESRD. It's once again higher in the hypertensive group than the non-hypertensive group, but when we adjust for the common reference point, we see the same risk in both. You're not safe from ESRD with a low GFR just because you're not hypertensive. And the same thing for albuminuria. The hypertensive group has the higher risk than the non-hypertensive group, but it's really the same, okay, compared to a common reference point. We then asked, what about if you have diabetes? Well, so this is all-cause mortality in the group with hypertension. All patients, all subjects have hypertension, but the red have diabetes. So diabetes and hypertension, that's obviously much worse for all-cause mortality than hypertension without diabetes. Okay? And this is the pattern. But when you adjust to the common reference point for each, okay, there's no difference in the relative risk. Here's the group who are not hypertensive. These are the not hypertensive diabetics compared to the not hypertensive non-diabetics. Big difference. But when you compare them here, we see the same risk. So this, remember, is the non-hypertensive, non-diabetic group. And this is the risk for cardiovascular for all-cause mortality. So a low GFR does not make you safe from risk, even if you have neither hypertension nor diabetes. Age. Let's move on to age. Age has been a big debate with people saying, yes, low GFR is bad, but low GFR is very common in the elderly, so is it really a problem in the elderly? And here we've done the same kind of analysis where we have 4 groups. The slides don't show very well. This is the youngest group, which has the lowest risk for all-cause mortality. This is the next group, the next, and these are the elderly. And I think this says this group is greater than 75 in blue. I'm having trouble. 66 to 74 in black, 55 to 65 in gray, and 18 to 54 in blue. So there's no doubt. Oh, excuse me. So here are the absolute risks. Older people have a much higher risk of dying than younger people. Okay? But when we adjust the risk, so we're comparing within an age group, we see that the relative goes up here for low GFR quite steeply, okay, in the elderly, much more steeply in the young. So this is what people have shown, a higher relative risk in the young than the elderly, but a much higher absolute risk in the elderly than in the young. Okay? And even the relative risk in the elderly is important. On the right panel, we see the same thing for urinary albumin. So older people are not safe from all-cause mortality if they have a low GFR. These are the risks for ESRD, and they're really, I won't belabor each curve, but really very similar relative risks for ESRD in the young and in the old. And these are the data in the CKD cohorts for all-cause mortality on the left and for ESRD on the right. And we have the same story. So in answer to this question, the results of all of these show a higher absolute risk in high-risk groups and a higher or similar relative risk in low-risk groups. And my interpretation would be that low eGFR and higher albuminuria are important in both high and low-risk groups, and lower eGFR and higher albuminuria cannot be considered normal in any subgroup, including the elderly. Another question is, are these thresholds applicable for other complications, such as shown here? And this has now been published based on results in 30,000 people in the NHANES survey in 2 separate publications. And just briefly, it turns out that for anemia, both eGFR and albuminuria are important. The same for acidosis, the same for hyperparathyroidism. For hyperphosphatemia, GFR is important. For hypoalbuminemia and hypertension, albuminuria is most important. And as far as age-GFR interactions, we do see interactions with hypertension and hypoalbuminemia, but there remains significant risk even in the elderly. And the interpretation is that albuminuria staging adds to GFR staging for these other complications, and older age does not lower the risk for complications of decreased GFR. So these new guidelines will be out shortly. I had the privilege of being able to participate with ADIR 11 as the head of the work group, and Katrine Uhlig, also at Tufts Medical Center, as chair of the evidence review team. So in summary, the controversy stimulated the formation of the largest collaboration in CKD epidemiology, leading to new consensus and a guideline update. We showed strong, graded, independent associations of lower GFR and higher albuminuria with multiple adverse outcomes, consistent across populations and subgroups based on diabetes, hypertension, age, sex, and race. It confirms the eGFR and the albuminuria thresholds for the CKD definition and provides a strong rationale for revisions to the guidelines. I'm going to skip over a number of slides in order to get to a summary. So we did have a big controversy, but I think that we have a substantial consensus. And this is a picture of Dr. Glassick and me after the conference, and we've been able to get along. But I think the most important thing is, how do we get along? We get along, and if we do, we can improve outcomes. But in order to do so, we need data. Data is what resolves a controversy. And in order to have data, we need collaboration. And we need good leadership to foster collaboration. Collaboration doesn't happen just because someone says, let's collaborate. You need leaders to collaborate. And our leaders need to be guided by a public health approach, because that's the way that they will force us to, or encourage us to work together to improve outcomes. So thank you very much.